I'm Sam. Welcome to Humans of Healthcare with another video. I'm here with Cari Epperson, who is my mom and one of my best friends, and I thought it would be fun to have her on. I'll let you introduce you and kind of go over what you do.
Okay, so I am a licensed clinical social worker. I previously was a special ed teacher and then decided later on in my career to go back to school and graduated from OU with my master's in social work and started my journey in the social work field. That was around 2016.
Yep. What made you want to go back to school?
So to be quite honest, I was frustrated with the school system.
A lot of people are.
And did not feel like I was getting the support. I worked with emotionally disturbed kiddos, and I found myself not doing very much schoolwork with the kids.
What were you doing?
It was more behavior management, working with DHS, trying to come up with different modified behavior plans, having multiple meetings with students and faculty and parents. And so I knew I always wanted to do something in the therapy world. I just didn't really know what it was. And so I decided to take a shot at it and got in, and that's where I am now.
So kind of describe what you do, like now.
Okay. So I wear kind of a bunch of different hats. Currently, I work at OU Children's Hospital in Oklahoma City. I work with the palliative care team.
Which is?
So pediatric palliative care is very different than adult palliative care. Anytime anyone hears the word palliative care in the adult world, they automatically think of hospice. That is somewhat true in the adult world. They do a lot more end-of-life type situations, pain management, psychosocial support, things like that. However, in the pediatric world, we have the ability to concurrently work with our patients in the realm of any type of terminal illness or medically complex illness. We like to get involved very on, whether it's a genetic diagnosis prenatally. We like to kind of follow the family long term. And we follow them when they go home. We call and do follow-up calls with them to check in on them after they're discharged. A lot of our patients are in and out of the hospital quite often. And so our team is an extra layer of support for the family. We first meet families. We like to get to know them, develop a rapport with them, find out what their goals of care are for their child. We talk about quality of life. We talk about good days and bad days. We kind of try to get a good idea of the long-term wants and needs of the patient and the family. And so, as you know, when you're in an inpatient hospital setting, whether it be ICU or on the floor, doctors change, sometimes on a weekly basis. Nurses change, sometimes day to day. And so anytime you have a kiddo that's medically complex, they have a number of different subspecialties involved, whether it be cardiology, whether it be pulmonology, whether it be hematology, oncology. So it's kind of the whole gamut. And so for our families, it can become very frustrating to navigate that world. And so what we like to do is we like to provide that continuity of care for the family so that no matter where they are in the hospital, that we will follow them. And so then we like to become their voice and talk with the physicians, talk with the subspecialties, talk about conversations that we've had previously about what their goals of care are and what they're wanting for their child so that the families don't have to retell their stories over and over again. The other part of it is that we not only try to provide that continuity of care for them, but it's really important that we develop a trusting relationship with them. They're in a position where they're in unfamiliar territory and you don't know what you don't know, right? And so being that we've worked in the field, we've followed families long term, we kind of know a little bit as far as what their journey might look like. Of course, we're not going to know exactly what they're going through because we're not personally going through it, but we just know what other families have told us. So then we try to educate them to become their best advocate. Our whole goal is that we never take hope away from our families. We hope with them, and we want to educate them to the best of our ability so that they can make the right decision for their family. We tell families all the time, there's no right or wrong decision. It's only what makes sense for your family. And so we try to really empower them to be able to become the best advocates for their kiddos. Most of the time, they're great advocates as it is, and they just need someone to hold their hand and help them along, and maybe give them some questions to ask the team members, or if they're not understanding a certain test, or if they're not understanding why a procedure is being done. We go through pros and cons, risk and benefits. We really look at the patient as a whole person. And we look at the long-term effects of every decision that they make along the way to make sure it fits within their scope of what they want for their child. Whereas the ICU attendings or the doctors on the floor, they're looking at day-to-day things. Right. And so that's what they're mainly focused on, is their day-to-day. Whereas when we come in, we look at the long-term and the full picture to make sure it makes sense with whatever their goals of care are.
Right. So working with, like you said, physicians, nurses, attendings, pretty much everyone who works on that individual patient. How do you get your communication across of palliative care? This is our team. This is what we want to accomplish. How is that taken from these physicians or nurses? Is it taken well usually? Are they supportive with you guys? Do you guys work as a whole, or is it kind of like you guys are off to the side?
So good question. So I've been in this role for 5 years, and I will say 5 years ago up until now, it has changed drastically. When I first came on board with the team, it was a nurse, a physician, and then myself. We've grown exponentially. So we have a nurse practitioner, and 2 physicians, and then myself now. Wow. When I first started 5 years ago, there was still a lot of the stigma attached to palliative care. So we had to really work and build up our program and educate a lot of people in the hospital of what palliative care is. Palliative care is not new. However, it is still new-ish in some areas. And so
I'm sure it's changing as well.
It's evolving. It's huge. So I just got back from Phoenix from the annual palliative care conference that they have every year. And there were thousands of people, all in palliative care, all from different areas, all from, different institutions and rural, urban, all of it. And so I would say 5 years ago, we had to educate a lot. That education come in the form of having a multidisciplinary meeting with all the team members. That comes from working in a interdisciplinary role. And we really had to develop not only rapport with the staff, but also the trust with the staff. Physicians in particular, surgeons, they go into the field to fix. They go in to heal. That's the reason that they want to go in. Nurses go into the position, and correct me if I'm wrong, to assist in making better. And so it's a big shift in perspective. It's a big shift in thinking. And so we had to really take the approach of, we're not here to take anything that you've done away. We're not here to take any hope away at all. We're here to join with you, and joining with you to not only support you, but also to support the family, and for us to work as a transdisciplinary team. And so we've done a lot of education. We've gone out into the community and done education. We were able to get a substantial grant. And so we've gone to multiple different locations and discussed pediatric palliative care. That has helped. And then I think last is when they started seeing us involved, and then they saw the result of us being involved. And that we're not only just there for the attendings, the physicians, the respiratory therapists, the nurses, the physical therapists, occupational therapists, because everybody's involved with our kiddos because they're so complex, but we're also there for them. So taking care of the critical population, or taking care of terminally ill patients, much less than being children, really can take a toll on the providers and really everybody that's involved with the child. And so we're there to also help support them. We do debriefs with the staff as well. If there is an end of life. It's funny because end of life is just a very small part of what we do. It's not the majority of what we do. And so I'm really proud of our program. I'm proud of how far we've come. And the director has worked really hard to get the program where it is today. So that's my hat in the medical field.
Okay. Very long drawn out answer. No, you're okay. So for those of you who don't know what a debrief is, kind of going through the end of life, or even nurses, physicians, anywhere in the health field, you've dealt with loss in some sort of way. I mean, family members, anyone in general has dealt with loss. But when it comes to in the hospital specifically children, there's a whole different aspect of it. And a debrief is what happens after end of care or a loss is happening at the hospital, where as much of the team, correct me if I'm wrong, gets together and almost vents about what happened. And it is an open area for anyone and everyone to come and just unload what had happened. And it gives us a place to kind of put all those emotions that just happened into one room with all the people who have experienced it together. And I think it's a great way to leave it at work, because so many people, especially nurses that are on that one-to-one care with them, tend to take that home, tend to go into their personal lives, which affects their work life at the end of the day. So those debriefs are super important, and we need people like your team to be able to lead that and orchestrate that. And I think that needs to happen, honestly, for every death in the hospital. And for every physician, for every nurse, for every, anyone in that healthcare field to debrief, whether it is in a big group with the palliative care team or seeing a counselor, which we'll get into, or, as a whole, just making sure that you talk it out.
Yeah. And another part of, and the debrief doesn't even have to be done at the end of life. A debrief can be done if a kid has crashed and they've had to do multiple rounds of CPR. A debrief can be done if a kid has crashed and they are having to be intubated or they're having to go on ECMO. Those things happen very, very fast at times. And so you are in somewhat of a crisis moment. So their bodies automatically go into hypervigilant mode and they're in fight or flight. And so it can be done for a variety of reasons. The other important part of having debriefs is talking about what went right and what didn't go right and what we could do better.
Which is so important.
Which is very important because that's how we learn, right? And we are human and everyone's human, and sometimes mistakes are made, and not that they're like big mistakes or anything like that. But I think anytime you're in that environment, you can always look back on yourself and see what you did good and see what you could improve on. And so that's important to move forward, just to help with other patients in the future.
Sure. Yeah. And if you are watching this and you are in the healthcare field, or even if you're not, I would love to hear either in the comments or whatever, how you debrief.
Yeah.
And different ways. I mean, you personally go through that because everyone has their own way of debriefing, whether that's, talking to your significant other, partner, whatever. But maybe if everyone can leave those comments, we can kind of, get new ideas. We'd love that.
Yeah.
Okay. So what are some things that you have struggled with when it comes to management in the hospital setting?
That's a good question. I think in any type of larger institution, there's always going to be things that you struggle with, as far as feeling like you're being heard, feeling like that your maybe thoughts, opinions, suggestions are being heard and validated. I think that, again, we're all human beings, and administration and higher ups are also human. And so we can't expect anyone to be perfect.
Right.
But I do expect them to be able to be vulnerable enough or be human enough to humble themselves
Right.
somewhat. And so some people will, say that those are pretty high expectations. And maybe they are, but I would like to think that everybody does the best that they can given the situation. But one of the main things that I would like to see happen in hospitals in general is that a lot of upper administration or anyone that is in a director maybe level have not always been a nurse on the floor. They've never maybe been on the clinical side of things.
Yeah.
And I believe that a bottom-up approach in leadership is the best route. And so in doing so, I think it's important that they go and they speak to the housekeeping.
Right.
That they go and they speak to, even the environmental people that are tending to the grounds of the hospital, right? All the way, from nursing all the way up.
I agree.
Because I think that is the best way that you get a good idea of how your hospital is functioning as a whole. And so I don't know if that's a struggle.
But feeling heard.
And feeling listened to.
Right.
Yeah.
Right. And that is across the board the answer I've gotten from every healthcare worker I've talked to is management making sure that they know what your job is. And that's a huge part of it. Even if they don't go through it, they know what you're doing on a day-to-day basis. And knowing that at the end of the day, even though they are management, they are still one of us.
Right.
And it doesn't make them higher up, doesn't make them anything, but just being a listening ear, if you're management or in that position, a listening ear goes a very long way.
Yes.
Whether that's, hey, just come talk to me and tell me how your week has been. Or, I saw or heard that this happened. Can you explain that to me the way you saw it, not the way management has heard it? I mean, you can go on and on, but feeling heard for sure is the number one complaint I've heard with management.
I think too, just overall, just having compassion.
For sure.
Just some normal compassion and empathy can go a really long ways.
Yeah. And leadership, especially, I feel like is the top people to get burnt out because they deal with the hospital issues every day. That is their job. And so it's very easy to get desensitized. And they need to realize, like you said, everyone is human. Everyone, has their own issues. So you said that you worked as a teacher for special education, and then you are moved to palliative care, and then you also do counseling.
I do.
Kind of explain to me how important throughout all of these careers that you've had, how important is family, the family aspect of your patients or their support systems? How does that come into play when you're treating them?
Well, I think it's huge. I think that family support or support in general for our families is sometimes what gets them through to the next day.
Yeah.
Unfortunately, we work with some families that don't have it. They don't have a grandparent. They don't have extended family members. And it is literally sometimes just the single mom by herself. And sometimes it's a very young single mom that has had to navigate all of the things by herself.
Yeah.
And so in those types of situations, that's another reason that I feel, or what I feel like we can bring to the families is the support aspect.
Yeah.
I think, and the support system doesn't have to be doesn't have to be family. So a support system could look like a church community. A support system could look like neighbors. A support system could look like friends. So it can look a variety of different ways, but having a support system is monumental.
Crucial.
Yeah.
We talked a little bit about bringing work home. How do you navigate that personally, not bringing it home? Because throughout, my personal experience with you is that she never really brings it home. As I've gotten older, we do debrief ourselves and talk about things. But growing up, I never personally saw you break down, to me. And I think that's very important of kind of having that line drawn. I'm at work, it stays at work, or I'm at home, it's time to spend time with my family, loved ones. How do you kind of draw that line?
So it's challenging, and just to be honest and vulnerable, I don't do it all that well all the time. And I think especially in the last couple years, it's been harder for me not to do that. Yeah. I would say first and foremost, having my faith and my religion is huge, and having my church family is huge. And then the other is I see a counselor too, right? And so that's another aspect of it. And I have a great group of colleagues.
Yeah.
It's really hard to go home and for someone to ask how your day was, and knowing that you had an end of life experience and that you were on the ground with a parent, consoling them, supporting them while they're wailing. It's really hard to put those types of things into words to someone that's not in the medical field. And so the worst thing what ends up transpiring out of that, if you're not careful, is isolation, which is the worst of the worst. So I'm very blessed that I have a great group of colleagues that I work with. We all have families, and we all love each other sincerely. I would say they're like family to me. And so having them to cry with, having them to debrief with on a regular basis, we know each other so well now that even if it's something that's not talked about at work, because we just haven't had time, we're all really good to check up on one another and pick up on, hey, I know this was really hard today. You want to talk about it?
Yeah. I love that.
And I have some people that are in the healthcare field that are very close to me. Like you said, we kind of talk about our days too. My best friend is a nurse practitioner. And so I have other people in my life that are in the healthcare field that can really understand
what you're going through,
what I'm going through.
Right.
Yeah.
And if you watched, really hope that wolf didn't do anything. Okay. If you watched our last video with Natalie, she kind of explained her fiance is in the healthcare field and she has that to go to. But if you are someone who doesn't have anyone to debrief with, I would highly encourage, one, getting your own counselor, and two, finding someone in the healthcare field that you trust and call them on the way home from work and call them when it's fresh on your mind. Like you said, don't isolate, don't drive home saying, what could I have done better? What could I have done worse? Call someone, debrief, get it out.
Yeah.
Kind of going into our last topic, explain how you got into this very new role of counseling for first responders.
So I've been seeing clients privately for a couple of years now, and I don't know how it happened, but a lot of my clientele were in the healthcare field and or military or in some form first responders.
Okay.
Not like, tons of them, but my regulars that I saw, I had a lot. Some of that I think was just being in a hospital setting and them knowing that I have that in my background. And so it's always nice to go to somebody that, again, understands, right? And so I did that for a couple of years, and here just recently, I've wanted to become more specialized in first responders, veterans, and frontline workers. It's such an important field, and there's a huge burnout rate, and there's a huge problem with mental illness in that realm. Not saying every first responder, not saying every healthcare professional, nothing like that, but it's a problem. And I wanted to be able to kind of specialize in that. And so I, through the grace of God, was blessed to find this company that I'm working for now that solely are wanting to work with just that type of population and are now expanding into the healthcare field.
Right. Tell us what that company is.
It's called First Responder Stress and Trauma. They started out in Texas and are moving into Oklahoma. The founder is a retired police officer who went back and became a psychologist. Most of the people there that work are retired in some fashion of police, FBI, and
all the things.
Yeah. And so they're a great organization, and their mission is something that I believe in, very much so.
I think specifically, as we've talked about, that population is the population that needs to talk to someone the most, especially, military deals with a lot of post-traumatic stress disorder or anxiety or things that cause their everyday living to be affected. And knowing nurses in general, I'm trying to think of a nurse that I don't know that is in therapy.
Yeah.
And that has came such a long way. There was such a stigma years ago of if you're in therapy, something's wrong with you, or you're crazy, or, all of the things. But I think it's important. I mean, I think I'm kind of selfish because I did grow up with you as a mom and having a counselor as a mom, but
I hated it at the time.
I hated it at the time, and I still do sometimes. But I think it's so important to find someone you can talk to, and whether that is a licensed person or not, every nurse needs someone they can talk to and someone they can vent to, and someone especially who's trained to talk you down or talk you through these things is so important. So obviously we encourage everyone to see someone and everyone to talk, because everyone's feelings are valid.
Yes.
No matter if you're in the healthcare field or not.
Yeah. When physicians go through residency and clinicals, there is not enough time spent on mental health.
No.
And I cannot tell you the number of physicians that I know that residency was some of the worst times in their life.
Yes.
And really, I mean, everyone has their own reasons, but, and again, let me preface that not every single physician thinks this.
Right.
I just know of a lot that went through some serious anxiety issues and some serious depression issues going through residency.
Right.
They are poor broke, living on ramen. They work sometimes 70, 80 hours a week and get all the bad shifts, sleeping in the hospital, and then trying to study their butts off. And it is a very lonely and isolating time.
Yeah.
And I think that can be the same for really anyone that's going for a license, right? In some type of medical realm. And so it's very important. Yeah. And it's not something that has to be done every week. It can be done once a month, right? It's just as important. We have to take care of our brains just as much as we take care of our bodies.
Exactly.
The two go hand in hand.
Right.
So it's just as important as eating right, staying hydrated, and exercising. Right. It's just as equally and as important, because it all flows together. So if we're going to ignore our mental health, it's going to come out in one shape or another, and it's going to come out in a physical way 9 times out of 10. Right. So that's where chronic illness comes in. That's where autoimmune diseases come in. Right. That's where gut issues come in. Right. There's a lot of things that stem from that if you don't go through and take care of yourself. And sometimes those are lifelong consequences of not doing what you need to do for yourself, right? Yeah. So, and it's important for your family. Your family wants you around, and you want to have the best quality of life that you possibly can while you're here. And so mental health is huge. And I think that society as a whole has come a long ways as far as the stigma associated with it. And people don't think that you go to a counselor or a therapist because you're crazy. Yeah. Whereas, some people before might have thought that going to counseling is not a weakness. Right. It's not a sign of failure in any way. It is not in any way, shape, or form something that makes you less of a person. Right.
I think that's so important because, like she said, the people who are treating you in your families go to counseling or, have mental illness, have anxiety, have all these things. It's not just you. I mean, it's everyone. Even your counselor obviously is going to therapy. Right. So it's important to know that everyone you are around needs help at some point in their life.
100%.
And if you are in the healthcare field specifically, I encourage every single one of you to go to counseling and to voice how important mental health is to all of your patients. Because 9 times out of 10, even if it isn't in the chart, every single one of us has some kind of mental illness or some kind of traumatic thing that's happened in their lives. And it's important to acknowledge. And I think we have come a long way, but there's so much more to do within it.
Right.
And so
we all have seasons in our life, right?
Seasons and reasons.
We all have our seasons and reasons, and we wouldn't be human if we didn't.
Right.
And not only is it helpful for you yourself as a healthcare professional to seek some type of therapy or counseling for your own well-being, but knowing what it will do for you and how much better of a provider you can and will become.
Right.
And then to also pay that forward to your patients.
Right.
So some of the best things is knowing that if you're, in the hospital and for whatever reason, we all do not want to be in the hospital, right? And so it sucks. It's a sucky time. And so how wonderful or blessed would you feel knowing that you had a nurse take care of you that could really identify with maybe your anxiety that you were feeling, right? And so, and again, that's what builds trust and that's what builds rapport at bedside.
Right.
To know that, for the patient to know that, hey, I am your nurse and I am here to take care of you, but I'm also human. And I also can identify with maybe the anxiety you're feeling because I have it too sometimes. And this is what I do to help. Right. And so that's a way for you to pay it forward. Right. That's a way for you to take care of your community. Right. So, and I think as a society as a whole, if we were that vulnerable,
things would change.
Right? If we were really honest with ourselves and really vulnerable enough to show our core authentic self to people that you trust, right? People that you felt safe with. I'm not saying everyone. Yeah. But if you were able to gift that to someone, what that might do for your patient. Right.
So, I think as a nurse, and I'm sure a lot of people can resonate with this, the best patients I had or the best experiences I've had as a nurse and why I wanted to be a nurse and why I continue to want to be a nurse is those days where I could sit with a patient at bedside and talk about real things and not talk about what medication I'm giving you and why I'm giving it to you or talk about, your diagnosis and everything like that. It's when I could sit down and really say, what are you feeling? And there is no walls. And I felt that too. I've been here, especially with labor and delivery. You just had a baby. My focus is on you. No one else matters in this aspect but you and how are you feeling? And those things go a long way. I mean, postpartum depression, everything like that is not talked about enough. And it's all wrapped up in what someone could have done at bedside. And I'm not saying that could fix everything, but what if it could?
Yeah. So one of the rule of thumbs for us is we try to always sit down when we go into patient's room. Yeah. Because there is something about standing and having, while they're sitting, I don't know what word I'm looking for. Yeah. And it allows them to know that, hey, they're going to be here for a minute. Right.
They're not rushing.
And that's the other benefit of us being a very small team, is that we have the time to sit down and get to know them. The attendings, for example, in the ICU, they're having to go. The nurses are having to go and be on their toes. And so that's so important, being able to take the time and sit down with the family and actually just be human with them. Right. And talk about the patient, right? We encourage families, hey, bring pictures up here. We're going to put them on the wall because we want the staff to see this patient
as a human,
not
as a patient,
and not where they are paralyzed and intubated.
Exactly.
Right?
Yeah.
And so, hey, what's their favorite Disney character?
Yeah.
What's like their favorite show? We are very blessed to have Child Life at our hospital. And so we can go to them and be like, hey, they are like huge Paw Patrol people. So can we get some Paw Patrol decorations? And so our Child Life goes in and they put Paw Patrol decorations up, right? And those small things go
right. I was telling you the other
forever.
day. Yeah, I was telling you the other day, my best friend who was a nurse in the ICU, she's a ball of energy and she will talk to anyone and everyone. And when I say that, I mean, she's walking down the street and she will talk to anyone and everyone. She is an ICU nurse and she called me the other day to debrief after and said, I had this intubated patient today, nonverbal, and she was giving him a bath and she put on her phone Kesha music while she was giving him a bath. And she was singing to him. I'm not sure if he loved the singing, which is completely fine, but she was singing to him while giving him a bath and talking to him and doing all these things. And it's so important to humanize these patients because just because they're intubated or nonverbal doesn't mean that, you know, they're not human. They don't have feelings.
Right. And unfortunately, people that are in the hospital, whether they're in the hospital for, you know, weeks or months, or whether it's, you know, days, whatever it is, life goes on.
Right.
Right. Bills still have to get paid.
Right.
We still have responsibilities. Right. And so, especially patients that are there for weeks or whatever, those families have to go to work.
Right.
They can't be at their loved one's bedside 24/7. They want to be able to, but unfortunately life doesn't stop, or they have other kids that they've got to get to school or they've got to pick up, or they have other kids that have activities that they still have to get into, right? Still trying to maintain some type of normalcy in their home in this chaotic situation. And so it's one of the hardest things for families is to leave the bedside. And I will tell you 10 out of 10 times, we advocate for our families to leave and go take a break. They have to. You cannot stay in the four walls, right? And the way that we get them to leave bedside is by asking them, who do you have the best rapport with as a nurse? Who do you feel you trust most out of the nursing that you've had? Write their names down. Yeah. And so what we try to do is get with the charge nurses, get with the nurse managers, and try to get those nurses there so that the family feels comfortable to leave. And that is the biggest thing that you can do for a family, is for that family to know that you are human and they trust you, and they trust you to the point where they might have not have left the hospital in weeks, but because they've developed the relationship they have with you, they feel safe with you.
Right. Thank you for coming.
Yeah.
If you have anything to add, definitely comment below and definitely ask us questions and we will be there to reply. Yeah. And do anything we can.
Bring on the questions.
Yep.
If you or someone you know or a loved one is having to battle any type of chronic illness or has any type of medical complexity and you just need someone to talk through things with, more than happy to do that. I try to do that with as many people as I possibly can. So bring on the questions.
Yeah. And make sure and call your mom. All right, guys. Thanks for watching Humans of Healthcare.
Hey, this is your host, Danny Mobley. Thanks for watching Humans of Healthcare. Please subscribe below for more great interviews.